Hi, everybody. It's Professor Miller. This lecture is going to focus on the alterations of the renal and urinary tract. We will discuss more in more detail, some of the abnormals like chronic kidney disease and acute kidney injury and things like that in class as well. This will just give you like that foundation of the abnormals and, essentially how they originate. So one area that I like to talk about is urinary tract obstruction. It can be anywhere along that urinary tract. So, it could be somewhere in the ureter or, lower down towards the bladder or higher up. It could be unilateral versus bilateral. I'll give you some examples on the next page too. It has an image with it. It can be complete versus non-complete, meaning that it's completely obstructed versus, partially. Acute versus chronic, that's another thing too. A good example would be like a kidney stone that's basically lodged in the ureter. That obviously is more of an acute issue because the kidney stone travels down and then it can cause an obstruction in that ureter. The big issue is that it impedes flow of urine, obviously, down from the kidneys through the ureter to the bladder, to be excreted. So obviously it poses problems for the kidney as well. You can have a functional defect or an anatomic defect. And I'll show you some images, like other things too, like BPH, like enlargement of the prostate. That can be a potential cause, or different cancers. If even, external to the ureters, if there's major compression there or constriction of that ureter, it can also, impede urine flow as well. This image obviously just shows a bunch of different areas that you can have, the cause of obstruction essentially. One, like I already mentioned, you could have a kidney stone, and it could obstruct anywhere, high up or low down the ureter, and then it impedes urine flow down through from the kidney essentially to the bladder. And what happens is that if you're impeding urine flow there, that it's not going to go down, and they can get what you call hydronephrosis, and we'll talk about that too, which is basically excess fluid or urine that's in the kidney. It's retained essentially. Other factors too, like even the prostate. So, I mean, these can even be occluded all the way down further by the bladder. And I'll show you some more images as we move through, but your prostate can actually basically put pressure on that urethra where it's exiting the bladder, and it can even cause it that low down where, they're getting an obstruction from very far down the urinary system tract. Even bladder cancers, and anything like that that impedes urine flow. So severity obviously is based on whether it's acute or chronic. Obviously the cause. Is it treatable, like versus like if we're talking about a stone? Obviously, there's methods that we can do to help the patient pass the stone, or even put a stent in to basically open up that ureter and let urine flow through there. How far up it is, or where the location of the obstruction is, how complete it is. Is it complete obstruction versus not complete? So all these factors obviously, can determine the severity of the urinary tract obstruction. And as I mentioned, the main thing that we also look at obviously is at the kidneys. Is it affecting the kidney? Because you can get hydronephrosis, and hydronephrosis is basically where they get enlargement of the kidney, but a lot of times it's because they have, their flow is impeded and they're not getting good flow through that ureter, so then they start getting enlargement of that, the kidney essentially with it. Ureterohydronephrosis basically is a combination of both, so it would be enlargement of the ureter, which your ureters are essentially here, and the kidney. So that would be, if they had, an obstruction that was a little bit lower down, that they're actually starting to get, affect their ureter and their kidney essentially with it. Hydroureter basically is accumulation of urine in the ureter. Hydro obviously means water. So basically, obviously, if you're not draining the urine, that's what's accumulating in there essentially. And if it's, if they have hydronephrosis, we worry about that damaging the kidney obviously as well too. So there's just a difference between of where the fluid is essentially with that. The big, number one factor that you commonly will see, in the inpatient setting or even outpatient is kidney stones. And they're called calculi, basically, or urinary stones. And they can be caused from different types of or different stones, essentially. They could be made up of calcium or they could be made up of uric acid. So the calcium stones are probably the number one. I would say about 80% of them are calcium stones. But there are uric acid stones and different ones as well. But basically what happens is they get crystals basically that grow and they literally form into like a stone. And that, unfortunately, they're really, really painful. These patients usually present with a lot of pain, but they can obstruct that urinary flow or the urinary tract. Obviously, they start up in the kidneys and they do shift around, or sometimes they'll start coming down, through the ureter. And that's typically when they start moving, that's when they start presenting with pain. And when their ureter, because the ureter is small and it has peristaltic activity, it's usually really, really painful. So these patients are usually in a lot of pain. There are risk factors for the development of kidney stones, things such as gender and age is more common in men. Surprisingly, even things like geographic location, and this really stems back to the temperature that they live in, essentially. This is what the thought process is, or what researchers think, that the temperature there, whether they live in like a very warm climate, because of perspiration. So if you're sweating, you're more apt to getting obviously dehydrated, and more dehydrated, or more frequent you're dehydrated, that's a risk factor too, because it's very concentrated urine, if that makes sense. So your urine is going to be more concentrated if they're dehydrated like that. And it just it predisposes them to calcium formation there. Same thing with seasonal factors. It's more common in the summer because patients it's because of the basically being dehydrated. Fluid intake is another one. Decreased fluid intake makes them more at risk because of the urine concentration. However, when patients start drinking a lot of fluid, it can start shifting things and moving things around. Sometimes they'll pass them. Diet's a big one too. Even when you think about like gout or uric acid, which gout is an arthritis from uric acid, but we basically educate our patients on the dietary factors. So like with uric acid stones, it's like things like meats, red meats that are high in purines, or a high purine diet can contribute to uric acid stones. Same thing with calcium. Calcium, a high intake of calcium can contribute to calcium stones. Occupation is kind of the same thing as it's more found with patients that are more likely to get dehydrated, whether they're not drinking enough fluids or they work in an environment that is warm, essentially. So it's kind of the same thing that we talked about with like the geographic factors or seasonal factors. So as I mentioned, they can be different. There's calcium stones, uric acid stones, and that's related to purines. In terms of formation, it's basically supersaturation of one or more salts. So there's a high presence of that salt or higher concentration, and versus the volume that's able to dissolve it. And some people are just prone to it. There's patients that too are they can be like overproducers or under excretors, meaning they overproduce some of these like calcium or uric acid, or they could be under excretors where they don't excrete it well. So there's other mechanisms that are involved in here, as well. But temperature is another one that contributes to it, or pH. So the pH of the urine is another important factor, like for the production of kidney stones. Ones like such as like uric acid stones or calcium stones, they tend to form more in like a acidic environment. Whereas another one I know I have on another slide is struvite stones, and that's actually related to like an infection, but those are usually formed more in like an alkaline environment. So sometimes the pH of the urine obviously can cause crystal growth. That's kind of how that is factored in. And then obviously with the crystal growth, they start to aggregate, and that's all it essentially means with aggregation. And that's how they get larger stone formation. Other factors for stone formation, crystal growth inhibiting substances. There's factors like, so patients like that have calcium stones, citrate is known to bind with calcium. So it'll basically bind with the calcium in order for it to be excreted. And that's actually a treatment sometimes for calcium stones is calcium citrate. So it's basically, it'll bind with it to decrease retention of it. Particle retention basically just means that you're retaining particles of it, and then they start to grow. They connect, or I'm sorry, they kind of stick together, like to form a matrix, and then that's how they get larger and larger over time. Different types of stones I already mentioned. Calcium oxalate, which is like a calcium or calcium phosphate stones. Those are probably the most common. The calcium phosphate's most common. Struvite stones is back essentially from, number one, it's more common in women, and it's typically resulted from basically a chronic infection. So basically, they form more common in women because women have more of a higher incidence of getting urinary tract infections, which I think I mentioned before in the first one. And a lot of it's related to our anatomy, with a short ureter, or I'm sorry, urethra, not ureter. Your urethra is the exiting part. Your ureters are higher up. So if you have a short urethra, then you're more apt to developing urinary tract infections. And then another thing too, as women go through menopause, there's a lot of tissue changes to the vaginal area and thinning of the tissues there. So just because of reduced estrogen, and they're more prone to getting UTIs as well. Anyways, I'm kind of getting off track, but that's basically struvite stones are related to an infection, and that's how they develop it. Uric acid stones are uric acid stones, so it's developed from high levels of uric acid. In these patients, too, it wouldn't be uncommon to see them have gout, because gouty arthritis is caused from elevated uric acid. And even in that case, they develop uric acid stones or crystal deposits in their joints. So the same kind of concept here, and it develops in their kidneys. In terms of manifestations or the presentation, we call it renal colic essentially, and a lot of times these patients are going to present with a lot of flank pain, and we also call it costovertebral pain. There's a costovertebral angle in the back of, if you were to look at the patient's back and under the ribs. Sometimes if we palpate on there, and you might have done this in assessment, or do this assessment when you get there. But a lot of times they'll have flank pain or abdominal pain or low groin pain with it. The other thing too is, even when we looked at like innervation of your bladder and your ureters and all that, that nerve path there, it kind of follows that groin area. So a lot of times patients will have like low abdominal pain with it, or even, vaginal pain or pain in their penis and stuff like that, in the genital area, just because of the nerves as well. But these patients usually present with a lot of pain. Sometimes nausea and vomiting with it. It's not uncommon. In terms of imaging, a lot of times they used to be, we call them a KUB, like a kidney, ureter, bladder x-ray essentially. So you're looking for stones on there, and that's exactly what this would be. And the higher density on x-ray will show up whiter essentially. So that would be like an example of a stone in a ureter. A lot of times now too, you can do ultrasounds, like you can see where the stone is, whether it's in the kidney, or if it's actually moving down through the ureter. And obviously too, we look at how the kidney looks too, or do they have hydronephrosis on there? Because obviously if they have a kidney stone, we worry about obstruction. The other thing too is we'll do like a 24-hour urine analysis, and this will look at excretion of like calcium. And a lot of times too, we'll actually evaluate the stones that the patient passes, to determine, okay, is it a uric acid stone? Is it a calcium stone? So that'll be sent to the lab to determine, what essentially the patient is predisposed to. But on this one, like you can do a CT. Basically, you can see the ureters on here, and obviously there's the kidneys. But you can see the little dots, like they'll have kidney. They could have stones up in the kidney. In terms of other presentations, like I mentioned, it's increased in men. Very, very painful. They may have pain that radiates to the groin, the testicles, abdominal area. Nausea and vomiting is usually very, very common with this. And even when you think about the response to pain, things like hypertension can present because, the pain response, obviously your blood pressure can increase with that. Other big key symptoms that you'll see is hematuria, so that's blood in the urine. And that's just because of the trauma to the ureters and the kidneys, essentially. They may complain of dysuria, urinary frequency, so any of those symptoms that you would get with any type of bladder dysfunction there. I already mentioned diagnosis. A lot of times we'll do ultrasounds or CT scans, stone analysis, retrograde pyelogram, which looks at the flow, looking at the urine pH, and even like a urinalysis. Do they have blood in their urine? Do they have an infection too? Because you worry about infection with it as well. Risk factors, I already kind of went through that. In terms of treatment, the big thing is prevention too, is trying to make sure that they maintain hydration on a normal basis, because obviously too, when it's more concentrated, when they're dehydrated, it becomes more concentrated and they're more apt to developing stones essentially. So fluid intake is a huge one. Decrease in dietary intake of those stone forming substances, whether it's like a low purine diet or, looking at their calcium in their diet. In terms of stone removal, a lot of patients, if they're large enough, they will have to get basically, a surgical procedure or lithotripsy. Lithotripsy basically is like high frequency waves that actually break up the stones into smaller fragments. So the patient still has to pass them. Sometimes, though, they'll put a stent in, like the ureter, because of blockage. And the stent in the ureter basically kind of helps calm the inflammation down, because it becomes really inflamed and swelled up, and then they have a hard time passing it. Or sometimes they'll even retrieve the stone in there too when they're in there. But small ones, if they're small, the patient honestly will usually just pass them. But we always make sure that they're straining their urine so that they actually catch the stones when they come out. Other types of urinary tract obstruction would be factors related to the bladder. And really, this is more of that lower portion. So when we're talking about the bladder, things like neurogenic bladder can be a problematic issue. And basically, it's related to your nervous system response there, or basically the nerves that innervate that area. So you can have detrusor. Remember, your detrusor is the muscle essentially for your bladder. You can have hyperreflexia or areflexia. Hyperreflexia means that it's an overactive response, where areflexia is underactive or a lack of response. So you may see things like this with a neurodegenerative disorder like MS, or you might see it with a spinal cord injury. But a lot of times these patients will present with like frequency, urgency, urgent continence. When you have hyperreflexia, they have an overactive bladder, symptom there essentially. And it's basically involuntary sometimes too. Like they may not have, like those contractions are not inhibited essentially, or they're uninhibited. The other thing too is like overactive bladder. Sometimes you'll hear it called OAB. Same thing, like these are those symptoms like they gotta go, with frequency, urgency, and nocturia. Basically, they, which is increased urination at night. Obstruction, a urethral stricture. So remember, these are lower again. So at the urethra, they could have a stricture at that very low point where they can't pass urine. Prostate enlargement's another big one, which with even like BPH or benign prostatic hypertrophy in men, one of the key symptoms is difficulty starting their urine stream, or they have a weak urine stream, and this is exactly why. Because in men, your urethra essentially passes right through that prostate. So when it's enlarged, it's basically puts pressure on the urethra or constricts it. So that's why they have urinary symptoms with prostate enlargement. Same thing with women, pelvic organ prolapse. This is not uncommon in like the older female. They may have where they have like a uterine prolapse, or even like a bladder prolapse. Basically, everything like those ligaments that hold it up, like hold your bladder up and hold your uterus up, become weakened over time. And, just the change in structure and the pressure that it puts down on the urethra, it can actually cause constriction there too. Usually with this, it's more of like a partial obstruction. It's not complete, but it can affect the flow of urine. I think that was it with that. I just added this image just so I can show you real quick, but in men, so this would be like the male bladder, but your prostate basically is right at the end of the bladder there, and the urethra basically passes right through there. So if you have enlargement of your prostate, it puts pressure on it, and that's why they present with symptoms of like decreased flow, or a weak flow or difficulty initiating a stream. So that's basically why. And the same thing in women, pelvic floor muscles, they become weakened over time too, especially women, they've had a lot of children. And, as they go through menopause, a lot of those structures change as well. But same thing, basically that bladder, everything starts to kind of weaken and it prolapses down, but it can actually cause constriction of that urethra. So it's not uncommon for them to start getting, urinary issues with it too. I added this because of the detrusor muscle, and I know I talked about it in the first one too, or first PowerPoint about micturition, basically, which is urination. But when you talk about like hyperreflexia or areflexia, it's all related to your nervous system. And remember that your external sphincter is under voluntary control versus the internal sphincter and your detrusor muscle are under that stretch receptor. So remember when the bladder fills, that basically stimulates those mechanoreceptors. And that's what signals up to the brain basically that it's filled. And then that's what causes the motor response right back down, which basically stimulates that need to void or the feeling to void essentially. But with dysreflexia or hyperreflexia, these patients obviously this can be impaired. And that's why I say things like a spinal cord injury or a lesion in the brain, like a major stroke or something like that. It's basically, it causes dysfunction with the nervous system that's basically innervating this process, if that makes sense. And that's why incontinence actually can develop as well. Or urinary retention. We worry about retention in patients too. And other things that I'll briefly talk about is tumors. Like a renal adenoma. Renal cell carcinoma is probably the most common renal carcinoma versus bladder tumors, like a transitional cell is like the second most common. But these patients, a big red flag that you'll see is hematuria with no other symptoms typically at the beginning. So if there's blood in the urine and we don't really have another underlying reason why, like if they had an infection, it wouldn't be uncommon to have blood in your urine, or you had a stone, it wouldn't be uncommon. So obviously if a patient has blood in the urine and we don't have anything else that's presenting with it, it's something that we have to be looking at. Obviously later down the road too, they may present with flank pain or changes in their kidney functions. But obviously at the beginning, they may not have a lot of symptoms with it. It's more common in men. It's usually like a 50 to 60-year-old male that is more at risk. Smoking is another risk factor for it too, and even bladder cancer. Smoking is a risk factor for that. Obesity, uncontrolled hypertension, those are other factors that have been found to contribute to it as well. And basically it's an adenocarcinoma. So it basically there's different types of cancers that are adenocarcinomas. And basically it starts like in epithelial cells with like a glandular tissue. So you can get adenocarcinoma in other areas, but this is just basically in the kidney. Bladder tumors, like I mentioned, another risk factor too is smoking. They tend to present with hematuria again, so they don't have pain with it or other symptoms with it, but they just present with blood in their urine. And these patients may not necessarily see blood in their urine. It may just be picked up on urinalysis, and that's very common. Like they won't see frank red blood in their urine. It's more microscopic, but it's a red flag. Once again, it's more common in men and smokers as well. In terms of urinary tract infection, which I'm sure everybody's heard of at some point, and you can have a urinary tract infection that just involves the lower portion of the bladder, or which we call cystitis, or when it involves the kidneys, we call it pyelonephritis. So pyelonephritis is basically when you have an infection up in the kidneys, which is more severe than just acute cystitis. So acute cystitis is just a bladder infection essentially. And what happens is there's a lot of inflammation of the epithelium, and it's caused by bacteria essentially. More common in women, like I mentioned, but we do worry about getting like pyelonephritis because it can travel up essentially. Another thing I'll talk about too is interstitial cystitis. And these patients present, it's more common in women, but they'll present with literally like the same symptoms of a bladder infection, but it will check their urine and they don't have any, indicators there that they actually have an infection. And a lot of times it's triggered by things like dietary factors, and I'll talk about this as we move through, but they present with those symptoms of having a bladder infection, but it's not necessarily related to infection. So we'll talk about that too. So in terms of symptoms of cystitis is suprapubic pain. So a lot of times they'll have pain that usually gets worse after they urinate. So a lot of times they'll have that feeling of burning or the urge, that real significant urge to urinate, but there's really no urine to even come out. So a lot of times they get like a spasmodic feeling there. Dysuria basically is either difficulty urinating or pain with urination. So that's a big symptom with it. A lot of times they have very frequent urination, very urgent. Like when they have to go, they got to go. And that's very common with a UTI or, cystitis. UTIs do happen in babies or kids too. In fact, if a baby or a child presents with a fever of unknown origin, like we don't know, meaning we don't know where the fever's from, like they checked, he doesn't have an ear infection or they don't have strep throat. The kidney is one thing that we always look at, the bladder. So, if there's just a fever there, sometimes they don't have significant urinary symptoms, but we'll always check their urine. So that is one thing that we look at in children. In the elderly, actually, it's really, really important. You will see cognitive changes in patients that develop a urinary tract infection in the older adult. This is very common. It's one thing we always look at. If someone has an abrupt change in their cognition, we look for a urinary tract infection in the elderly patient. And obviously there's a lot of risk factors there. Some of them may be incontinent, where they're, where they have to wear Depends. So it's just an environment that they can easily get a urinary tract infection. But when you see cognitive changes in a patient that are abrupt and they don't typically have, it's one thing we always look at. Other symptoms that may be present, they should actually not be present. If you have a fever with just a regular urinary tract infection, we're suspicious of pyelonephritis because fever typically does not, unless it's a child or even the elderly, but in the average, young adult or adult, they should not have a significant fever with just a, urinary tract infection. If they have pain that's higher up at that costovertebral area, like I mentioned in the back, kind of like what I mentioned about flank pain in the back under the ribs, that is another significant red flag for potential like a pyelonephritis in that patient. In terms of UTIs, the most common pathogen is E. coli, and it makes sense. Obviously, E. coli is, in your bowel in that area too. So that's the number one pathogen for UTIs, E. coli. There are other pathogens as well. So that's why we always do a culture on patients too. So we'll send it out, because you do have to know what bacteria it is, because obviously now there's different bacteria that patients are exposed to, or even if you think about the hospitalized patient, if they have a urinary catheter in, they're at high risk for infection. So, anytime we introduce anything, whether it's, a line or a catheter, they're at, increased risk of infection. So a lot of times they may have atypical bacteria, that you wouldn't typically see in the outpatient setting. I already kind of went through this. So the big ones is the frequency, dysuria, urgency, suprapubic pain. If they're starting to get back pain, then we're a little more concerned, obviously, about pyelonephritis. Obviously, treatment is antimicrobial therapy because we have to eradicate the bacteria. Big things, too, is making sure they're taking in fluids or getting a lot of fluid intake. Avoidance of bladder irritants, that's a big one, too. There's certain things that are very irritating to the bladder, like coffee, teas, wines, things like that. Alcohol, smoking is very irritating to the bladder. So, eliminating those factors at that point in time. Urinary analgesics, that would be like pyridium, which, basically it's like a topical analgesic for the bladder is what that is. It doesn't get rid of it, but it helps with the symptoms or, basically treating them symptomatically. But they have to obviously take antibiotics. And once again, we'll talk about this in class too about cultures, because once again, it should be sent out and making sure that they're on the right antibiotic. Interstitial cystitis, like I mentioned before, they present very similar to like having a bladder infection, but it's very chronic. It's not bacterial. So if you were to send the urine out, look at it, they wouldn't have any bacteria in there. It's really an inflammatory process. I mean, so is a UTI, but there's no bacteria there essentially. It's very common in women, younger women, 20 to 30 years old. but they present very similar, where they have that burning, they feel full, like their bladder feels full, but they still have small urine volume when they go. The problem is that there's not really a great effective treatment for symptomatic relief. And in fact, a lot of it is actually dietary treatment and eliminating certain dietary, foods or drinks from their diet to eradicate symptoms. And actually, here is, these are basically, I don't expect to memorize. I'm just trying to give you examples, but things like I mentioned, and these are irritating to any bladder, whether, in the male, female. So if you're having urinary symptoms, sometimes elimination of these factors can actually help. Big ones are like coffee and tea, carbonated beverages, alcohol is a huge one, smoking's a big one. Artificial sweeteners is another big one. So essentially, with these patients, we try to eliminate the irritating foods, essentially. In terms of an upper urinary tract infection, that would be like pyelonephritis. So that's when we're starting to get an infection up in the kidneys. A big contributing factor is reflux. So vesicoureteral reflux, basically where the sphincter there is not tight or closing well. So they actually get reflux back up into the kidney. But then it predisposes them to getting an infection. And actually, this is one thing that we'll look at in children is reflux. If they get, it's not that common for a child to keep getting UTIs essentially. And if they are, it's one thing that we look at is reflux basically up into the kidney. The problem is too, like with patients with pyelonephritis, if they get it chronically, it becomes a significant inflammatory process where they get persistent episodes that become basically lead to scarring of the kidney. So then they're obviously too at risk for down the road of kidney failure. Or chronic kidney disease, I should say. But a lot of times, it causes like inflammation and scarring in the kidney if they have it chronically. With acute pyelonephritis, so they're going to have those symptoms of dysuria, urgency. So they still tend to have those bladder symptoms, but they're more severe. They're going to have fever, chills, flank pain. They may have nausea and vomiting with it. It's usually ascending, like I added on, this is on here, meaning that it's starting from the bladder and going up. Descending can happen, but it's less common. So meaning like if they had septicemia or infective endocarditis, where they have an infection in the heart, or septicemia, it can end up in the bladder. But that's less common, obviously. That's, usually ascending is more common. This is just an image, like I mentioned. If they have chronic pyelonephritis, obviously that's where they start to get the swelling and inflammation of the kidney. Well, it puts them at risk for kidney disease. So, obviously, we want to prevent that. Another factor that we'll look at is glomerular disorders, so glomerular nephritis. So when you look at these, think about your kidney functions when we talk about the kidney structure and functions and the nephron and all that, and the filtration and, fluid and electrolytes. Because now when we start talking about like kidney disease, obviously that's where all of these problems kind of come into factor here. So with glomerular nephritis, there's different causes of it. Like there's actually post-streptococcal or post-group A strep, essentially strep throat. They can get glomerular nephritis after. But basically it's inflammation of that. They can have immune complex abnormalities. Remember when we talked about hypersensitivity reactions where they get the immune complexes? Well, it deposits in the kidneys and then they can end up with inflammation there. Drugs or toxins is another big one. So, there's a lot of drugs out there that are nephrotoxic, so they can damage the kidneys. Vascular disorders, whether, they have stenosis of the renal arteries or something like that. Obviously, this can damage the kidneys too. Systemic diseases, another one that I always think of is like lupus. Lupus can definitely cause, issues with the kidneys. Viral causes like hepatitis and HIV, those are things too that can affect the kidneys as well. Mechanism of injury. So like I mentioned, you can have those antigen-antibody complexes, like when we talked about hypersensitivities. So this is actually kind of a common cause where they get these complexes that deposit there. And then it basically causes like an inflammatory reaction, and then that's when they have damage to, or they get glomerular nephritis essentially. And then you have non-immune, like I already talked about, like toxins, drugs, ischemia, so that's lack of blood flow. This is just some image. Remember when we talked about filtration of the blood in fluid and electrolytes that essentially occur through the nephron? So obviously, too, like what happens is that you end up with damaging of that filtration unit. So with this, they end up with basically like a leaky, basically it starts leaking, and then they start developing where they get protein that's essentially going out into the urine. So a lot of times when we start seeing proteinuria, that's when we're thinking, okay, is there something going on with the kidneys, or there's damage to, the filtration unit there? Because typically, as you remember when I talk about in the first one, larger molecules like protein should not be able to penetrate through there essentially, and it shouldn't be secreted in the urine. That's when there's a kind of a red flag there, obviously, when they start having protein in the urine with it. So big things, I already said before, proteinuria. So if they have a lot of protein in their urine, that's when you typically look at, an insult to the kidney. And a lot of times we'll do a urine dipstick, or they send it to the lab, and it'll come back with protein or albumin essentially in the urine. A lot of times too, like in a patient, like even like diabetes nephropathy, they will have like micro albuminuria. So it's like a small micro level, like where it's not as significant as it would be with this. So they're having a high level of protein in the urine. They also can present with hematuria, so basically red cells in the urine. Casts is another thing too, and we'll talk about the urinalysis in more detail, but another thing too, like with casts, like you can see that with damage to the kidney too. With this, they may have oliguria. So basically that means a reduction in the amount of urine output. Typically, over a day, I would like the typical urine output is anywhere from like 1 liter to 2 liters. Sometimes it's the average per hour, they'll say at like 30 mLs an hour. But obviously with this, they're going to have a reduction of it. And they start holding on to fluid because they can't essentially maintain that fluid, like the water and sodium balance anymore. So when they're retaining it and not secreting it, they can end up with hypertension, edema. So, they have decreased urine output, so it's not going anywhere, so they're holding on to it essentially. So like I mentioned, a lot of times, like a big one that you'll see was with a recent strep infection where they'll have the antibody antigen complex. And ultimately causes inflammation, which ultimately affects the filtration rate. And remember, your GFR basically is how well your kidney is functioning. So if it's reduced and your kidney's not filtering well, then obviously you're not excreting urine, and all those other factors like your electrolytes can get out of balance as well. So then they start holding on to, fluids. That's why they have higher blood pressure. That's why they get edema. They can have a low-grade fever with it. Proteinuria, hematuria, oliguria, so they have decreased urine output with it as well. So when you have, an issue like this, you can have acute kidney injury. So it'll be called AKI, or acute renal failure, people will call it. So, they're just named, some people will call it acute injury versus acute renal failure. And when you think of acute kidney injury, it's important to understand the difference between where it's originating, because it can be a pre-renal issue, it can be a renal issue, or it can be a post-renal issue. Pre-renal meaning anything that is feeding to the kidney. And a lot of times, obviously, pre-renal is going to be perfusion. So if you don't have enough blood flow going to that kidney, it's going to change the pressure and the filtering in that kidney. So they're at risk for acute kidney injury. They don't have good perfusion. They don't have good flow there. It could be renal, like an intrinsic issue. So they could have damage within the kidney, whether it's like glomerular nephritis. That would be like an example. So they can have a damaged portion of the kidney or an intrinsic factor that leads to it. Or you can have post-renal. meaning obstruction, which is why I wanted to talk about like kidney stones and obstruction. If you have an obstruction there, the urine's not be able to drain. It basically backs up to the kidney, and they can get acute kidney injury or acute renal failure with it. So the big thing to understand is that you can have pre-renal, renal, and post-renal, and we'll talk about this more too. Other causes of acute renal failure, or I'm sorry, this is the same thing, I just have it in a different slide. Pre-renal, so sudden severe drop in blood pressure, whether it's shock or they have an interruption of blood flow to the kidneys from severe injury, severe dehydration, hemorrhage, etc. So that would be pre-renal because it's before the kidney. Intrarenal would be things like nephrotoxins, like drugs, acute inflammation, like glomerular nephritis, a major infection, like pyelonephritis. If it's severe enough, it can lead to acute kidney injury. Post-renal would be obstruction. So that's things that are that don't let the kidneys flow out urine. So it backs up, and then they end up with damage to that kidney, essentially. And that could be anywhere from stones in the kidney, ureters, a bladder tumor, a significantly large prostate, or even injury or stenosis of the ureter, essentially. So it's one of those three areas that essentially are, precipitating acute injury to the kidney. Prerenal is the most common cause because it's related to blood flow. So anything that's going to decrease blood flow to that kidney is going to decrease GFR. Basically the pressure in the kidney, because a lot of us, it's the same kind of thing if you think about like oncotic pressure and blood flow through there. Obviously, if you're going to decrease that, you're going to have a decrease in filtration as well. So that obviously decreases the function of the kidney because that is, your GFR is looking at how well your kidney functions. So the most common cause is basically related to impaired renal blood flow. Intrarenal would be things like acute tubular necrosis. Acute tubular necrosis is commonly caused by nephrotoxic drugs. This would be like the most common cause of intrarenal. Basically toxic, necrosis to those tubules essentially within the kidney. And remember your tubules are basically right after your glomerular or glomerulus, basically right after there. So if you have injury, and like I mentioned before, sometimes it can be nephrotoxic drugs that can cause that too. So that's a common cause of intrarenal. Or glomerular nephritis is another one that would cause it too. Post-renal, I already mentioned, obstruction after the urinary tract. This is just an image that I had. It basically just goes through, it's just another image that you can look at, but pre-renal, post-renal, intrarenal, looking at like acute tubular necrosis, which I already kind of mentioned. And then basically the signs and symptoms, like if they have decreased urine output, and we'll talk about more of these too. When they have acute injury to the kidney, at the very beginning, it's just kind of the initial insult. That's when it first comes on. And this is really when you want to catch it because obviously we want to remove whatever's insulting the kidney, whether it's a medication or increase perfusion to the kidney, whether it's a blood flow issue. So we want to catch it obviously early. So it's kind of the start of it, and they don't really tend to have that many symptoms at this point. But then they kind of move into like a different maintenance phase where they become oliguric, meaning they have decreased urine output. So this is when it's significantly low. They aren't going to be putting out a lot of urine. And as I mentioned before, that's why it's so important to look at your patient's urine output too. Obviously in conjunction with how much they're intaking too. But serum creatinine and their BUN is going to increase during this time. Because remember your serum creatinine and your BUN, especially your creatinine, it gives you a good indicator whether there's an insult to the insult to the kidney essentially with it. And then you have the recovery phase where they become polyuric. So they actually start increasing their urine output with this time. So they have more diuresis actually at this point. So they'll actually be putting out more fluid than they would typically. And typically, like I mentioned, it's like 1 to 2 liters a day. And that's obviously if they're getting normal hydration or normal fluid status. But at this point, they could be putting out 5, liters a day, 4 or 5 liters a day. So they're getting rid of all that excess fluid essentially. And then their trends and their creatinine and urea will start to go down at this point in time. And Creatinine clearance will actually increase, and we'll talk about that too with labs, because we actually look at the creatinine clearance when we're looking at the filtration of the kidney and how well it's functioning. But we'll talk about that more later as we talk about labs. This is just a chart that I kind of, I thought it was good. It's the same thing that I kind of mentioned, that, they have different phases where they have an oliguric, where they have basically very little urine output, which would be like below 400 milliliters a day. It could even be even lower than that. But, were there significant risks for electrolyte disturbances, acidosis, fluid overload, and really try to think about this. Why would they have hyperkalemia? Why would they have acidosis? Because when you think about the secretion of bicarb or hydrogen ions from the bladder, excretion of it or secretion of bicarb in the kidneys, all of this gets out of whack. So that's why they're at risk for, all of these issues, whether it's electrolyte disturbances or acidosis essentially, or even fluid volume overload. And then they're at risk for heart failure because they have all this fluid on board. So really patients with a lot of kidney dysfunction, especially chronic kidney disease, this can obviously is problematic too, but they tend to have a lot of underlying problems and a lot of other issues like with electrolytes and all that too. So when you think about it, try to think about it in perspective of why would you see electrolyte disturbances or acidosis essentially in these patients. Obviously with acute kidney injury, we also worry about chronic kidney disease as well. There's different risk factors for, chronic kidney disease and even acute kidney injury, but increasing age, race or ethnicity, African Americans or Hispanics have a higher risk. Genetic factors, hypertension is a huge one. So long-standing hypertension because it's affecting the blood flow to the kidneys. Same thing with diabetes, it affects the blood flow. Metabolic syndrome too, because they usually have, they tend to have high lipid levels. They tend to have hypertension, and sometimes they tend to have diabetes as well. But we worry about, basically a chronic kidney disease development, and we want to halt that process essentially and protect the kidneys. I'm going to go ahead and put, the next slide is chronic kidney injury. I'm going to go ahead and put that on the next video, so that way it kind of separates a little bit, and then we'll talk about chronic kidney disease too, and we'll talk about these in the class as well. If you have any obviously questions, we will discuss this further, but just let me know if you need anything. Thanks.